Thank you very much, all of you who are joining us here in person and remotely. We have a great combination of talks today. We are going to start off with Matt Robichaud. He is one of our third-year emergency medicine residents. He is going to be talking today about several different pediatric toxidromes and how we best manage them. All right. I'm sorry, let me just quickly say, neither of our presenters today have any financial disclosures, okay?
Is that on? Can you hear me all right? No? Yes? All right. So thank you, Dr. P. Yeah, pediatric toxidromes and what to do about them. My name is Matt Robichaud, PGY3 in emergency medicine. Probably know most of you guys by now, hopefully. I have two computers here because my notes didn't come up, so I apologize for that. All right, and as Dr. P said, I don't really know what resident has ever had anything to disclose, but definitely not me. If anyone's lining up to give me some money, I'm very happy to take it, but unfortunately no one yet has offered, but I'm all ears. So objectives for today, very simple. We're just going to review 3 cases of common pediatric toxidromes and what to do about them, antidotes, and management. All right, so our first case today is a EMS calls in. It's a 3-year-old male with altered mental status. Mom says the baseline for the kid is usually like this, but he's presenting today a little bit closer to this. Initial vital signs show that he's not looking too bad. His blood pressure is 130/85. His respiratory rate is 18. Heart rate's 90, and pupils are about 2 millimeters, so he's a little myotic there. While you are basically getting the kid on the monitor and everything, you notice that the blood pressure drops now to 70/40. Respiratory rate gets worse, and pretty much all around it's just not looking good. It becomes bradycardic down to 38. So right there with that presentation, myotic pupils and kind of tanking, what are you guys thinking? Well, a couple of things, right? I mean, there should be like 2 or 3 differentials that run through your mind with a toxidrome lecture. So you're thinking either an opiate or possibly something that mimics that, which would be clonidine. So turns out mom tells you, well, her boyfriend just moved in and started taking a new medication for blood pressure, taking clonidine. So clonidine is tricky because it's going to be difficult to differentiate between opiates and clonidine. The classic board question that we see a lot, at least on our in-service practice boards, is usually they present with hypertension initially, and then they kind of bottom out, and that's sort of the differentiating factor between clonidine and opiate overdose. Also, the bradycardia seen with clonidine is pretty significant and much more profound than you see with an opiate ingestion. So you become a little more hemodynamically unstable. And then look for the myotic pupils as well. So clonidine, what makes clonidine such a dangerous medication is its pharmacokinetics. It's basically got all the badness associated with it. It's really fully absorbed by the body very easily. Has very high bioavailability. It's got a large volume of distribution, and its half-life just goes on and on, 6 to 24 hours. It's renally excreted. This picture, what is bioavailability? That's still an existential question I'm struggling from med school, but. So clonidine dosing, I think this is a couple of things to be aware of that you kind of just need to know the relationship between the dosing and the medication, especially for toxidromes in the ED. So the general blood pressure medication for clonidine is very similar to the ADHD treatment. They're both about 0.1 milligrams per day, and that varies depending on the provider, and they might escalate that dose. For those of you that are equally mathematically challenged, I've done this complex mathematical equation for you. 0.1 milligrams is equal to roughly 100 micrograms. I rounded that to make it easy for you all. And a mild overdose of clonidine is about 10 mics per kilogram. That's when you start getting some of the hypertension symptoms. You can start to see yourself fade into the bradycardia, but really around 20 mics per kg is where you start getting the respiratory depression, the coma, the apnea, and the stuff that's really scary for the kids. So if you think about a 20-kilogram little kid, just 2 to 4 pills can potentially put them into the 20 mics per kg level. So So really, and these are really small pills, as you can see from the picture, it doesn't take very much. And we've seen, we've seen a ton of this in the department. Last year it was the #1 ICU admission in Australia for toxic overdose was Clonidine. I don't know what it is here, but it's got to be up there. I mean, it's probably one of the most common serious overdoses that I see, at least in the ED. All right, so continuing with Clonidine overdose treatment. So what are we doing about this? In the ED, you really have usually one of two options for anybody that comes in pretty toxic. You're usually either giving benzos, or you're giving supportive care, or you're giving both. Those are kind of our two go-tos. Obviously not benzos for this, but Clonidine is really supportive care, steps 1, 2, and 3. You want to support the kid hemodynamically, respiratory, and with their heart rate as well. So adjuncts to that, you can use atropine to help with their bradycardia, 0.02 milligrams per kilogram, up to a max dose of 0.5 mg per kg. That's your basic atropine dosing for most stuff in the ED for pediatrics. Also, norepinephrine is your go-to #1 pressor for this in patients that are becoming hemodynamically unstable despite fluid resuscitation. So you're obviously going to go to IV fluids with a 20 cc per kilogram bolus first, but after that, we're starting norepi. And then what about naloxone? So there's a lot of talk about naloxone in the ED, and we'll talk about that in a minute, but the take home on that is probably not empirically. And then for this particular case, you got this kid coming in, he's lethargic, he's looking bad, he just swallowed these pills. What about activated charcoal? What do you guys think? Yeah, it's almost always the wrong answer for almost every question ever. Very, very rarely is activated charcoal, although I did give it like 2 nights ago for a girl in the PVD. However, basically, stay away from that. Anybody who's even has a whiff of unstable, lethargic, altered mental status, there's too high of a risk of aspiration, so we just stay away from that completely. All right, so naloxone. This is a case report in the literature done in 2015, which essentially concluded that there isn't really a defined empiric role for giving Clonidine overdose for suspected, naloxone for suspected Clonidine overdose. That being said, I think why it's in our literature as much is because it's kind of almost an EMS parameter now, because you get into a situation where you have no airway support, you can't resuscitate, you can't get the kid to breathe, you can't ventilate them, and you're really out of options. You don't have a lot of intubation equipment, you don't have the whole ED bay, so you're out in the field. And I think it's very reasonable that they give 100 mics IV every few minutes. They titrate that up to a respiratory response. Hasn't been shown to have great outcomes, but it's something to think about if you're kind of on a Hail Mary situation. And then obviously the rest of it we talked about, atropine for bradycardia, mechanical ventilation when needed, fluids and pressors if you have to go there, and then admit them to the PICU. And that being said, I was thinking about this case is a lot of times kids, in a case presentation it's very easy to have, I just told you what the problem is, but you have a kid comes in undifferentiated sick, right? It's scary, and you don't always know what to do, and you're not always completely positive this isn't opiate or concomitant with Clonidine or multifactorial. So sometimes you're just going with throwing a couple different things at them. There's not a lot of downside to giving a little bit of naloxone, but this paper just concluded there's really no justification for empiric use on a regular basis. So just something to keep in mind there. All right, so to summarize the section on Clonidine, it's a pretty ubiquitous drug. It treats hypertension, it's ADHD. It's pretty much everywhere. Very easily ingestible for these kids. High bioavailability. The toxic dose is not that high. It's 10 to 20 mics per kilogram. And then we're treating it with supportive measures and then adjuncts or atropine intubation, fluids, norepi, and then naloxone if you have profound refractory hypertension, you can consider it. All right, so the second case. So again, EMS calls. You got a 4-year-old with altered mental status, lethargy per mom, and EMS is saying minimally responds to verbal stimuli, something diaphoretic, which is always a bad, scary word to me in the ED. EMS is unable to establish IV access, so we're kind of already running into a perfect storm here of scary stuff. Vital signs en route are heart rate of 166, respiratory rate of 37, blood pressure 112 over 73, chem 98. So we're looking all right. I mean, I don't like that heart rate. So while you're triaging the patient, they have a full tonic-clonic seizure, which is always intense to see and very dramatic. So the first thing you do in emergency medicine, you always go through the mantra in your head, which is for all of our oral boards, which is IVO2 monitor. And then I say IVO2 monitor, and then you check. Kids seizing, what are we checking? Glucose, right. Okay, thank you. Glucose is 33 on this kid, but I always think IVO2 monitor, check glucose when I walk into a room with any critical patient, especially kids. Something to think about. Turns out glucose is 33. Mom tells you grandfather does take a diabetes medication, doesn't really know which kind, so you empirically treat the kid with some dextrose, but much to your chagrin, 20 minutes later, kid's seizing again, full tonic-clonic, seems to be refractory to your treatment. All right, so what do you guys, any ideas or something like that? What medications are doing this to you? So these are all your sulfonylureas, right? They present with profound hypoglycemia. You treat them, they get worse. They have profound rebound hypoglycemia. I've seen this multiple times in adults. I haven't seen it in kids yet, but I've had to admit many patients to ICU for being on a dextrose strip. It's still bottoming out. So your classic sulfonylureas are glyburide, glipizide, glimepiride, everything that starts with G. Kind of just go with, hone in on that, a glip or something. Their mechanism of action is they increase insulin release from the beta cells in the pancreas. The medication is well absorbed by the body, and then it peaks around 4 to 8 hours, and it's got a long elimination half-life, which increases, it's one of those medications that increases as you escalate the dose. And then overdose, this is surprising, but can result in up to 72 hours of persistent hypoglycemia. That's for the extended release version of the sulfonylureas. All right, so back to the case. So remember, the kid's seizing. So we got our ABCs, Ds, and Gs, airway, breathing, circulation, disability, and glucose, as well as we're going IVO2 monitor and glucose. We're always checking that. So after you get the kid back on another glucose check, after he's seizing for the second time, he's got a glucose of 28. So you start giving some dextrose, and you're like, all right, I know what to do. And then the nurse tells you the IV is infiltrated. Patient's still seizing, now he's becoming cyanotic, and you're getting a little worried here. So while our team members are working on trying to get the IO set up and the IV, you remember what to do because you trained at Carilion, best residency place ever. And what do? You go right to your IM glucagon. So you do not need an IV access to treat hypoglycemic seizure patients. IM glucagon is incredibly effective. You just have to know the dose when you tell the nurse it's 0.03 milligrams per kilogram. If you're really up a creek and you don't remember, you can just give them a milligram of glucagon IM, and it's very effective. Obviously, IV dextrose is preferred if it is available and if you have a working IV, which oftentimes in a seizure patient who's little who comes in, you don't. So it's something to think about. Sometimes you can get an IO. It's not always the saving grace we think it is because they're actually harder to get sometimes in little kids than you realize. The pediatric dosing is pretty straightforward, but it's a really easy way to remember it because medications, I don't know if you have a hard time during codes and during high-stress situations remembering all the doses, but I certainly do. But if you have D5W at bedside, which you can always get from the cart, you can just give a 5 to 10 cc per kilogram bolus, which essentially gets you your 0.2 gram per kilogram push. If you have D25 at bedside, you can just give a smaller bolus. Now you're just pulling up 2 to 4 mLs per kilogram. And then finally, ideally, if you have some D50, you just pull up, I just think of pulling up 1 ml per kilogram. So you got a 20 kilo kid, you pull up 20 mLs, you give that as a slow push. Max dose of that is 25 milligrams, and that's really what an AMPA D50 is, right? An AMPA D50 is 25 grams of sugar. So pulling up the 1 to 2 mLs of D50 kind of gets you there. All right, so what's another adjunct medication that is really now kind of standard of practice, at least in the ED, for somebody with sulfonylurea overdose? Anybody know? It's a pretty classic medication. It's actually, I'm going to show you some literature. It's actually a life-saving medication. Is Octreotide. So Octreotide has come on the market as a somatostatin analog that blocks pancreatic release of insulin. It's very easy to dose. Again, I just round everything. Sub-Q is just 1 mic per kg per dose. and you just give it once, usually every 6 to 12 hours based on the response. It actually is preferred to give it sub-Q rather than IV because it has a better side effect profile with its hypoglycemia. It does often cause hypoglycemia, but you can prevent that by giving it sub-Q. It's an incredible medication. And how well does it work? So this is a study. Obviously, much of what we do in medicine, we like to think it's evidence-based, but really it's not, right? It's based on a lot of expert opinion. Things are constantly changing. We have one trial that then trumps another trial every few years, and our practice is constantly growing and changing, as should our learning and our education. But up until 2013, there really was no great clinical evidence for using octreotide. They basically had some case studies and some expert opinion, but they did a review in 2015. They had 121 cases that met inclusion criteria, where pediatric patients were given octreotide for overdose on sulfonylureas. The study concluded, and I think this is worth reading, it decreases the number of hypoglycemic events, and this is throughout the hospital stay, not just in the first 24 hours. And ultimately, they checked like hourly blood glucose concentrations, and they had a higher basilar level of glucose than the kids who didn't get it. And then the majority of kids only required one dose, which I thought was interesting. And then most importantly, when you study a medication that isn't really approved necessarily by FDA for something, what is the side effect profile? And it was a great side effect profile. They had no adverse outcomes in children who received octreotide compared to those who didn't as far as the medication side effects. So that's something to keep in mind. I think it's really standard of care now for us. I think you guys in the ICU are going to see it a lot too. I know we admit people all the time for this, so something to think about giving a dose of octreotide if we haven't already given it in the ED. All right, so let's go through sulfonylurea overdose summary. Persistent hypoglycemia. So these are not people, these kids will trick you because they will come in, and adults, I've seen some adults a ton, they'll come in, they look like awful, and you resuscitate them, you give them some glucose, you give them a little drip, they look better, and they're like, I want to go, I've just had a little hypoglycemia, what's the big deal? And then 20 minutes later, while you're getting ready to discharge them, your attending walks over and says, hold on, did you see the second glucose? And it's back to 40. So these guys really can just keep bottoming out on you, so you have to be aware of that. Use your basic resuscitation skills when dealing with this, right? It's always A, B, C, D, and then followed by G, glucose check every time. IV dextrose preferred, but if you're out of IV and you can't get an IO for whatever reason, knowing that if you can't remember the dose, at least remembering that there's IM glucagon, and you can look it up quickly at least. But you can just give them a milligram IV glucagon for emergent treatment. And then the octreotide, I think, is really pertinent with 1 to 1.5 mg per kg sub-Q to prevent persistent hypoglycemic events. And then at minimum, at least the recommendation is at least 24 hours, depending on how they do clinically. But you can actually, you can make them longer. I like this symptoms of hypoglycemia slide because it's funny, when I saw it, it kind of brought back some flashbacks to when I was rotating on pediatrics with Dr. Keys as my attending. Anxiety, shaking, I mean, they're all there, right, when you're presenting a case to them. And all right, case 3, our final case for today. This is a 3-year-old who, or 6-year-old presents to the ED. Mom says he's coming from a friend's house with severe and violent nausea, vomiting, diarrhea, and abdominal discomfort for 5 to 6 hours. However, you go in there, the kid looks pretty good. His kind of symptoms are gone. Looks a little wiped out and dry, but he's otherwise looks pretty well. And then you're trying to keep this face from popping up because the last 22 patients you've seen, the mother said it was severe and violent, and you've never seen a presentation like that before, of course. So while you're in the middle of presenting to your attending, and you're just getting a kid ready for discharge, you're always in the middle of some sentence that goes like, oh yeah, this kid looks great, right? The nurse runs in and tells you he's clinically deteriorating, he's vomiting again. And then you ask the nurse, well, did you give him the PO-ODT Zofran I ordered? And the nurse at that point just looks at you, rolls her eyes, and then grabs the attending and tells him to come to bedside. And you're left there wondering what you did wrong. And when you walk in, things are going pretty badly. The kid is deteriorating. He's now added hematemesis to his list of accolades here, and he's also got epistaxis. So he's resumed his vomiting, he's got diarrhea, he's clutching his abdomen, he's now becoming a little lethargic, his vitals are really starting to look a little bit worse. You're pretty concerned now, but you got normal temp, so you think, hey, we're doing all right. You ask yourself, you ask the nurse, say, hey, can you put an IV, give a 20 cc kilogram bolus, you're proud of yourself for knowing to do that, and then you ask for labs, and at this point, you know, as an intern, you pretty much order everything. I think like an ANA came back. I mean, every test you can ever think of because you're freaking out, and the kid's really just looking bad. But he comes back with some concerning labs that match his clinical case, which is he's got a lactic acidosis of 4.1, his creatinine is 1.8, his PTI and R off, he's got a metabolic anion gap acidosis, and his LFTs are elevated. Now you're like, this is just really not going well. So you come back, and while you're in there, the attending gently nudges you to, could you get a little more history from the parents? And I'm going to do a couple of things. And so while you're doing this, they go and astutely order a KUB because they kind of already have an idea of what's going on. And I don't know if you guys do or not, but you know, what is GI complaints bad for in a toxidrome lecture? It could be anything, but we're talking tox. So they go get a KUB, and it shows this. All right, so what are we concerned about with that? Yeah, this is an iron toxicity case, right? This kid came in with a classic presentation, became shocky, and you didn't get the history of a toxic ingestion, but do we get a history of that always? No, maybe half the time if we're lucky. Do we have an idea of what's going on when the kid gets there, especially when they're sick, because everybody's freaking out trying to get them to the ED, as they should be, I get that. But the EMS doesn't always have time to figure out exactly what's going on, and the mom might not know either. All right, so acute iron poisoning, to go over this for a minute, iron is a direct GI irritant, and that's actually the most common initial presentation of it, usually abdominal pain, nausea, vomiting, diarrhea, and then hematemesis is actually pretty specific for iron toxicity. If you don't have it, I mean, it's about 50% of patients coming in with iron toxicity will actually have hematemesis, so something to keep in mind. All that nausea, vomiting, diarrhea results in hypovolemia very quickly, hypotension, tissue hypoperfusion, and metabolic acidosis. Doses as low as 10 to 20 milligrams per kilogram can cause toxicity. And then adult iron supplements, which shockingly are shaped like chewy, sugar-coated little gumdrops, I can't understand why a kid would ever eat them, have about 65 milligrams of iron. So, you know, you get into those and eat 4 little gummies, and a 30-kilogram kid is in toxicity land. So something to keep in mind. It doesn't take a lot, and to keep that stuff out of reach. And just while we're on the topic of supplemental over-the-counters, if you think that they're awesome and you're counseling your patients, you might want to read some of the studies. This is a study that I actually heard on Wait, Wait, Don't Tell Me, which is my #1 news source for the most part for scientific new studies. But they did a test. It was a pretty nicely done test where they looked at 44 different herbal supplements, and they found that only 1/3 of the ones sold in the U.S. had anything, or didn't have anything in them that was related in any way to what they were selling. So echinacea with 0 echinacea was rice. And this goes on and on and on. And the other 2/3 aren't doing much better because a lot of times it would be substitution or it would be like 1% of something just so that you could write it down on the label. But it's really, be very careful when you're doing that. All right. So I want to go through, because I think it's pertinent just for boards, but also for real life. There's 5 stages of iron toxicity. I've had questions on each of these stages before. Stage 1 develops with, pretty quick, within the first few hours of ingestion. You get the GI symptoms like we talked about. Hematemesis is common. Interestingly enough, if there are no symptoms within 6 hours post-ingestion, you can send that kid home because it is impossible that they have reached a toxic level. That's that specific. You will have GI toxicity if you took enough iron to cause a problem. So keep that in mind if you're watching a kid trying to get the dispo done in the ED. If they look good 6 hours from, they come in 3 hours post-ingestion, you watch them for 3 hours, they can technically go home potentially if you're comfortable with that. There's the next phase, which is the false sense of security phase, which is probably the scariest. That's when all the GI symptoms abate, right? That's where our kid presented. He was really sick, kind of felt better, This can last a couple hours after the ingestion. This is all spectrum, right? Nothing ever follows these guidelines, but it's kind of on a spectrum. But kids start to look better, and you're feeling more confident about being able to send them home. Third phase is PGY1 phase, hours to, after the second phase, which is the kid gets really bad, and all the badness starts happening. They go into shock, the lactic acidosis. They have iron-induced coagulopathy, which is terrifying. They go into hepatic cardiorenal failure, also incredibly scary. So this is when you really are practicing your resuscitational skills, and hopefully they're getting up to the PICU at this time so they can get a full PICU evaluation and all the support they need upstairs. But remember how to resuscitate these kids. And then stage 4 is really sad. That's when they're 2 to 5 days post-ingestion. That's when their liver really starts to shut down. They go into fulminant hepatic liver failure, and they have elevated transaminitis, obviously. And if they are able to survive that, they are left at stage 5, which is about 4 to 6 weeks post-ingestion. They develop gastric outlet obstruction due to their pyloric sphincter being just destroyed by all the iron toxicity. So this is not a great outcome. So just a reminder to get there early, be aggressive, resuscitate these kids. It might be their only chance to sort of abate some of these symptoms in the future. All right, so what do we do for iron treatment in the emergency department? We've touched on a few things. First, always a good idea, call poison control. They are so nice. I don't know how you guys call them upstairs, but they're just awesome. They're always polite. They always have great things to help you with. Usually it's like supportive care or benzos, but there's occasional times when they actually do provide you something you hadn't thought about it. And it's a really nice service that we have here, so I recommend you try it. Again, if no symptoms within 6 hours, can DC home and then go through resuscitation. The next step for after you've resuscitated the kid is you can do a gastric lavage if it's been within 60 minutes of ingestion, which is pretty rare for us. But then the thing that we can do in the ED, which I've actually seen before, is you can do whole bowel irrigation with polyethylene glycol. And the dose for that is 250 to 500 cc's per hour via NG tube. So you have to insert an NG tube, and I highly recommend using some Versed for that if they're stable enough to help facilitate it, if they're not already intubated and sedated. And then early and aggressive antiemetics. I know that seems simple because we give Zofran to everybody, but this is somebody you want to be really aggressive in because these kids are really suffering with the nausea vomiting symptoms. So be aggressive with that. And then they recommend vitamin K and FFP to help correct some of the coagulopathy from the iron dose. All right, and our mainstay for treating is deferoxamine, right? This is like the classic board question from step 2, and everybody for the rest of life will want you to know this. So just remember, it's a chelating agent. It removes iron from tissues. The dose is 1,000 mics per IV with an initial rate of 5 milligrams per kilogram per hour, and then total is 360 within the first 24 hours, or a max dose of max dose of 6 grams in 24 hours. So what are we treating towards? The way we evaluate how our treatment is going is we do serial urine samples, and then ferroxamine is excreted into the urine as a byproduct, and it changes the urine to something called a vin rosé appearance. And I tried to get Dr. Powell, who's our wine connoisseur, to give me a video of him tasting some of these wines, but I couldn't quite pull it off. He did, without missing a beat, when I asked him to describe a vin rosé in the setting of ferroxamine excretion, immediately without missing a beat said, if it looks like Pinot Noir, you've gone too far. So that's a Powellism, as we say, in the ED. I don't know if you peds guys have met him yet, but he's fantastic. And then you admit to the ICU. All right, so iron poisoning summary. Let's just hit the high points of what I want you guys to remember. It doesn't take much to get into toxicity land, 10 to 20 mg per kg. GI upset and hematemesis, if those two are together, it's iron poisoning until proven otherwise. Don't miss this. Don't be the person that was like, well, they looked all right. There's a little hematemesis. You got to always think badness when you're in the ED. First thing we have to rule out is the worst thing. Remember the 5 stages of iron poisoning. If you don't necessarily have to remember all of them, but have a working understanding of the sort of spectrum that they run on. And then antiemetics with an NG tube is incredibly important. Obviously, ABCDG, fluids, vitamin K, FFP, gastric lavage. And then just remember deferoxamine. You can call you need to remember those doses. You can call the poison control. give it to you, write it down, you ask the nurse to give it. It's pretty straightforward. Oh yeah, please talk to your patients that eating some of that does not make you do that, so they don't get confused. I wonder about why these kids are taking so much iron, but all right, so that's my references. All right, guys, do you have any questions?
Okay, we'll see if there are some questions. While we're unmuting, I just want to say a couple of things. Thank you to the Department of Pediatrics for the lovely breakfast. It was really fantastic. And welcome to the pediatric residency candidates. We hope you enjoy your day here. This is just one example of the kind of interdepartmental collaboration that we really think sort of defines what happens here at Carilion. So enjoy your day, talk with our happy residents about their experiences here, and we hope to see you.